So basically, it's a very elaborated topic. So I'll try to briefly cover carotid stenting. Uh, Innovation is the ability, to adapt to new situations and perceiving them as opportunity, not threat. As we all know, this was the past and are to be probably. And just slides are not showing here. Next one. These are the certain heads I will be discussing: prevalence, evidence, timing, indications, imaging, word about surgery versus stenting, emergent cause. Mukesh talked about tips in technology to reduce embolization, stent design, production device, and our own experience. Well, moderate to severe carotid stenosis, it is in 10% of general population. Our Indian own data, which is a stroke patient primarily, and our own data, it amounts to around 10% to 15%. Well, you all know the first evidence that if you revascularize symptomatic carotid stenosis way back by NASET in 1991, so you have absolute risk reduction of let's say 17%, and these all were symptomatic patient with more than 70% stenosis. Obviously, when you talk of indications, contraindication to surgery are clear-cut indication for stenting, previous neck surgery, radiation, surgically not accessible lesions, long segment of stenosis, tandem lesions, hyperacute stroke, dissection with hemodynamic compromise. So these are clear-cut indications, and their relative indications are high-risk patients, contralateral occlusion, high-grade stenosis. Well, just to show few cases, this is a patient with post-radiation stenosis, long segment of stenosis with a pseudo-aneurysm sitting here. The patient was pressing his neck and he was having recurrent TIA. So this was a long segment, opposite ICA was occluded. So we did this conjoined stent technique, took care of this pseudo-aneurysm, and patient became alright. Relatively young patient, tight stenosis, clear indication. He was having recurrent TIA. This is a patient with acute dissection with hemodynamic compromise, and this needed stenting. This is another patient, again a dissection, you can see here. But in this patient, we did contralateral femoral puncture, recanalized the vessel. Once you have a complete filling of circle of Willis, so probably you leave these patients as such and don't stent them. Timing, window period nowadays, this is, because we have in window period in first 24 hours, these patients ultra early, especially if there is stenosis without infarction, no IVT was done. Deferred is up to 2 weeks, which is commonly done, and there is no literature to use stenting after 6 months or so. Well, interestingly, the whole idea of if you do stenting in a large or moderate size infarct, something called revascularization. You open the large vessel, but all these capillaries which are 2 to 5 micron in size, when you have acute stroke, there is what is happening there is edema of endothelial cells, there is edema of astrocytic foot processes. So you can see here very well, and these endothelial cells become very leaky, and lumen is compromised significantly here. So just pushing or gushing more blood by opening through a stent very early in the stage might lead to something called no reflow. So you have done recanalization, but you have not done reperfusion to the capillary level. So this is something which needs to be understood. Stenting versus surgery, the debate is probably over, but for the sake of completion, I would just go, there are few landmark 6 trials which we named. So some of these trials, especially which, like surgery were better, EVA3S and ICSS, it's commonly cited. So basically these trials have very loose operator requirement. Those people who have done 5 stenting or probably 10 stenting in their whole career, they were putting stent into femoral or renal arteries. So they were eligible to do procedures. Those people who have done 5 stenting or probably 10 stenting in their whole career, they were putting stent into femoral or renal arteries. So they were eligible to do procedure. So you really cannot compare. So these loose investigation or operator requirement was a very big flaw in those trials. CREST was the largest trial. We all know about CREST, but this was the largest trial which showed that stenting is non-inferior to surgery. I'll be skipping most of the, and now we have data up to 10 years. Younger patient, better outcome, higher degree of stenosis, get risky with surgery, more the experience, better it is. And my personal opinion for all these trials, because I'm not very big fan of all these trials, because I actually do not believe in degree of stenosis that much. I'll be showing you, because none of these studies considered mild or non-stenotic plaque. Carotid bulb is a dilated area. It's unusual size. So what happens if there is a plaque, and especially which is growing eccentric, lumen will not be compromised. So a large plaque may not produce any impressive luminal stenosis. So that's a very important thing. And what is the morphology of the plaque, which is the biggest determinator? So these are the guidelines. So when you do your imaging, that depends upon what you and your institute are best at. Ultrasound, CTA, MRA, DSA. We do MR based because I do plaque, imaging. So traditional luminal imaging is not adequate here, and it is easy to do MRA plaque imaging because it's a superficial artery. It's a palpable superficial artery which is remote from lung and heart motion artifacts. It requires some labor. It is labor intensive, and it needs surface coil. But once you are familiar with this, you can do it better. Because for me, most important thing is plaque morphology. MRA plaque morphology and histopathology correlate well, whether it is a lipid component, fibrous tissue, or intraplaque hemorrhage. So this is what our protocol is. So I'll not be going in detail. So a fibrous cap, you can see very well fibrous cap. You can see the lipid component here, and this is a different patient. You can see some irregularity and ulceration. Here you can see some floating thrombus. So it tells you a lot. It tells you about everything with a MRI, and this can be done even with a 1.5 Tesla machine also. See, we all are very much concerned about a blister leading to a subarachnoid hemorrhage. But what happens when there is an intraplaque hemorrhage? So intraplaque hemorrhage is one of the biggest determinant of stroke recurrence. So these are the plaque imaging, especially if you see here, these are the plaque which are not producing significant luminal stenosis. You see here carotid looks pretty okay. Carotid looks pretty okay here. So don't let yourself be fooled by these images. There is nothing here. There is no significant stenosis here. So there is an intraplaque hemorrhage here, which is a determinant of stroke recurrence. Same thing, intraplaque hemorrhage, mild degree of stenosis. So this is what we did. We did this 80 patient which we published in stroke. So we did this mild stenosis, 30 to 50% stenosis patients. So there was a case, there was a control. So asymptomatic, symptomatic in the same patient. When we analyzed these patients, it was very clear that intraplaque hemorrhage, ruptured fibrous cap, and a mural thrombus, obviously. So these were determinants. So 30% of so-called cryptogenic stroke patients where you don't find a cause. Probably it is a mild carotid stenosis which is responsible in sizable proportion of these patients, because these are often missed because our all imaging is dependent upon luminal narrowing. So plaque morphology is probably the way to go ahead in future. So this is what it was. And this we published a couple of years back, because I am a firm believer that a plaque has to be stabilized. That the whole target of treatment has to be plaque stabilization. See, you do optimal best medical management. As of now, it takes 6 to 12 months for a plaque to stabilize. If you do some kind of anti-inflammatory agent or putting a stent across a plaque, which is like putting a dressing on the wound, so that promotes endothelialization within a month's time. So you make it a fast plaque stabilization. I'll show you how. Then I come to another etiology of these plaques, a morphology which you see here. There is something you don't see. So probably this is a case where you did a recanalization You took the thrombus out. Etiology of these plaques, a morphology which you see here, there is something you don't see. So probably this is a case where you did a recanalization, you took the thrombus out. We subjected these consecutive thrombus samples to new generation sequencing. New generation sequencing will pick up even if there is single bacterial DNA in the given plaque. Culture will be negative. So the idea of picking up these are the bacteria which are sitting in and around our body, like on the skin, oral cavity. They are commensals, but they make plaque vulnerable in a way, and that is why we tried to establish that. We isolated 27 such bacteria, and we proposed and we published this also. Their mechanisms: they make acidification of plaque environment, they do have some biofilm forming properties, they have some local proteolytic action, so they produce plaque rupture. So this plaque rupture would lead to an event. So it is not only the degree of stenosis. If you have a 90% stable plaque, probably nothing will happen. So various mechanisms, this is the summary of those mechanisms. So you need to have faster strategies for faster plaque stability. Well, there are certain things. This is initially, because it's very difficult to do a drug trial. I mean, in present scenario, you need so many approvals and things. You have something called turmeric. It's in our home. So turmeric, which is curcumin, which is very potent anti-inflammatory medication. What happens over the years, we are going for more and more potent antiplatelet. Statin does have anti-inflammatory activity. Aspirin does have. But newer and newer antiplatelet, they are more blood thinners rather than anti-inflammatory. The problem here is inflammation is probably key to development and vulnerability of the plaque to rupture. So more anti-inflammatory property, curcumin. Curcumin is available. So you cannot give a drug. So what you can do, we did this trial. I mean, first of all, we all know it is safe. Curcumin is safe. But we needed to produce, so we published this safety study first, where now we have almost 100 patients. We gave them a glass of milk with 2 teaspoonfuls of turmeric, which amounts to 500 milligram of curcumin and 1 milligram of piperine. Piperine is nothing, a dash of black pepper, that's piperine, which increases bioabsorption. So we gave consecutively, we randomized these patients. Rather, this kind of RCT was amazing, because a patient I was giving turmeric milk, the another one was asking, though it was with the informed consent. So this came out very well. Though we do not have data for 100 patients as of now, but their MRS tend to be better at 30 days. So this is what my message is, that you need to have more anti-inflammatory agents which would have vascular endothelial growth promoting agents, rather than going in one direction only, limonene potent blood thinners. Well, Mukesh has already discussed about emergent CAS, which was a new thing, because nowadays we do a lot of acute stenting also. These are the various. So basically this is in tandem lesion. He has already talked about it. So treatment with acute cervical IC stenting is associated with higher odds of successful reperfusion, though with somewhat increased risk of hemorrhage. There are set of patients where you have a small infarct, TT3 recanalization, poor or incomplete circle of Willis, there is active reocclusion on DSA, there is lower risk for bleeding. So these are the subset of patients where you can do acute stenting at the time of doing your mechanical thrombectomy. Because initially, this is one of my very old patients where he had a small infarct, and I thought this circle of Willis is okay, pretty okay. 7 days later, he has a large infarct. So these collateral were not sufficient enough to keep it, for keeping the stroke recurrence not to happen. So sometimes collateral, same way, another patient. So nowadays we were not doing acute stenting early on. Nowadays we do more often. If you have, as I said, there are certain group of patient, another patient. This is another patient, acute stenting. Something like that you have, which is a hemodynamic impairment to supply. Again, acute stenting in the acute state. It was a large one. Well, since I have been working on blood biomarkers for acute stroke from long, so probably there is some role of biomarker also, which you can have some prognostic idea, because we usually do it before mechanical thrombectomy biomarker. If it is So it's already published thing. The only thing is we are trying to come down to clinical thrombectomy biomarker. If it is, so it's already published thing. The only thing is we are trying to come down to narrowing the time, because it takes 1 hour for a result to come, which really doesn't work. We need a point of care test so it can give you quick results. So that we are working upon. Well, there are certain tips and technologies to reduce stroke during CAS. Procedure, keep it simple. I mean, the average time for me is 4 to 5 minutes. I think for most of the operators who are experienced do like that. And adequate lesion preparation is the most important thing. Don't be putting your efforts into dilating the stenosis, putting balloons and hardware. Use minimum hardware. Prepare your lesion very good. If you are thinking that you have a jelly-like material, please don't stand them. There are other things also. So because most of stroke would occur during post-dilatation. Well, so a way to avoid this is sometimes to minimize stroke, you can do a radial CAS or you can do direct transcarotid stenting. So these are I will not go into details of these things, but you avoid aortic manipulation by doing this. What about stent design? Symptomatic patients, closed cell design. So here you can see this lattice is closed cell, so tins are connected. Here you see tins are open. So probably open cell design are meant more for asymptomatic cases where you have tortuous vessels. This is again same thing, closed cell. And now we have hybrid stent also, which are closed cell design in between, and on the ends they are open cell. As the free cell area would increase, there would be more events. So that's a basic common sense proved by many studies in the past also. So this is depiction of those things only. Well, now we have these 3 trials because all the filter we use today are their pore size is more than 100 micron, most of them, and most of the embolic debris which goes to brain during the procedure is less than 100 micron. So as I said, sometimes you need for a capillary size is 2 to 5 micron. A 5 micron debris would occlude the capillary. So none of these stent filter devices would work. So basically, most of these particles are less than 100 microns. So that's one thing to remember. And based on that, the new stent developed. So what was that? These 3 studies, and these are the 3 stent came up from these studies. A road saver, which is a closed cell nitinol frame, and there is an inside nitinol micro mesh inside this. Then you have this carotid stent, which is open cell nitinol frame, and outside there is a PTFE lattice. So you can see here there is a membrane over it. Okay. Then you have C-guard, which is open cell nitinol frame, and outside this you have PET micronet. So because of this, so earlier we were having either closed cell or open cell. Now we have these dual layer mesh stents. So probably they would produce lesser microemboli. This was the idea, and there is this whole list of stents we have. Well, there was a caution about the dual layer stent. They have more thrombosis problem, sometimes acute thrombosis, sometimes delayed thrombosis. I just a couple of more minutes. So basically, but I think still we do not have much experience. Maybe others would have. I don't have much experience. I use them. In very few. Others would have. I don't have much experience. I use them. In very few patients only. So the future stent should be one which would have faster plaque stabilization. It should prevent plaque prolapse like these dual layer stents. You may have some drug coating by anti-inflammatory, antibacterial, because we have microbiota also as etiology, endothelial promoting agents, statin and antiplatelets. Last word, 1 minute. Protection devices. Distal, we have distal occlusion balloons, proximal occlusion devices, and filter devices, which most of us are using. So basically, as I said, most of filter devices we use has porosity of 100 microns. So anything less than that, something. So this is again atherosclerotic material, which mimics like strawberry gel. So this will not be prevented by any filter device. So that's what I'm saying. Doing a good MRI plaque imaging, knowing the composition of the plaque, whether it's a lipid core-rich plaque, it's an ulcerated fibrous cap, or there is intraplaque hemorrhage inside. So this would tell you vulnerability of your plaque instead of just using mechanical devices. Or so this would, because nowadays, of course, now there is another balloon which has come up, which is the smallest pore size balloon, that is Paladin. This trial is also published, which is 40 microns. So smallest pore size Paladin balloon is 40 micron. Still, I would say this is insufficient. So because of that, so nowadays some people do this proximal protection device. So this is like, what they do is they would not, they would just put this kind of balloon in the ICA, balloon in the CCA. They would produce no flow or reverse flow here. So it is under protection. There is reverse flow, so debris do not fly up in the brain. So these are proximal protection devices. But as I said, I think probably because every device, more and more hardware you use, it's going to, because most of my patient, 90% I would not be using protection device. But I do good lesion preparation, I do good plaque imaging before I intervene in them. And recently we crossed CREST trial number 2500, so we crossed that number also. Most of the time we use only, definitely 90% time we use Abbott or open cell Equilink or Exact. I'm not promoting them, but this has been my experience. So our complication overall has been less than 1% so far. Thank you very much. So this is the message I want to give here, that we should look these plaques from a different perspective. We should not go by these trials.
I think it was a very good study you see. That means you stent all symptomatic carotid stenting. The plaque is vulnerable.
Yes, ma'am. I mean, I'm not saying that. I just did few studies, but I'm of the opinion that if it is 40% or 30% stenosis with a vulnerable plaque, I would tend to stent it, or maybe I'll prepare that and I'll stent it.
And you do the plaque study at the time the patient is suffering. You do your first MRI with the plaque study.
Yeah, because our acute protocol, stroke thrombectomy protocol is also MR based. So
Right.
obviously at that time we will not do plaque imaging. But when you are taking the patient, because in very early stage there is no only TIA, there is no infarct, no IVTP has been used. So obviously you can stent that patient. And biomarker I showed cell-free plasma DNA, which has come up from our lab. If it is less than 2000, we are very sure that there is not much of neuronal damage. So this is in the first 48 hours. But then most of the patients, as I said, I would wait for a couple of weeks. If it is moderate to large infarct, I would wait, let the inflammation subside, then I will stent. But before that, I will do plaque imaging.
Have you done any regular plaque imaging to see that the patients you have not stented, when the plaque stabilizes, like in general?
Yes, that's what I'm saying. I mean, some of these patients, when we started, stenting, what we did was we have done proximal protection device. So this is like, what they do is, they would not, they would just put this kind of balloon in the ICA, balloon in the CCA. They would produce no flow or reverse flow here. So it is under protection. There is reverse flow, so debris do not fly up in the brain. So these are proximal protection devices. But as I said, I think probably because every device, more and more hardware you use, it's going to, because most of my patient, 90% I would not be using protection device. But I do good lesion preparation, I do good plaque imaging before I intervene in them. And recently we crossed CREST trial number 2500, so we crossed that number also. Most of the time we use only, definitely 90% time we use Abbott or open cell Equilink or Exact. I'm not promoting them, but this has been my experience. So our complication overall has been less than 1% so far. Thank you very much. So this is the message I want to give here, that we should look these plaques from a different perspective. We should not go by these trials.
I think it was a very good study to say that means you stent all symptomatic carotid stenting. The plaque is vulnerable.
Yes, ma'am. I'm not saying that. I just did few studies, but I'm of the opinion that if it is 40% or 30% stenosis with a vulnerable plaque, I would tend to stent it, or maybe I prepare that and I'll stent it.
And you do the plaque study at the time the patient is suffering. You do your first MRI with the plaque study.
Yeah, because our acute protocol, stroke thrombectomy protocol is also MR based. So obviously at that time we will not do plaque imaging. But when you are taking the patient, because in very early stage there is no only TIA, there is no infarct, no IVTP has been used. So obviously you can stent that patient. And biomarker I showed cell-free plasma data, which has come up from our lab. If it is less than 2000, we are very sure that there is not much of neuronal damage. So this is in the first 48 hours. But then most of the patients, as I said, I would wait for a couple of weeks. If it is moderate to large infarct, I would wait, let the inflammation subside, then I will stent. But before that, I will do plaque imaging.
Have you done any regular plaque imaging to see that the patients who are not stented, when the plaque stabilizes, the inflammation?
Yes, that's what I mean, some of these patients, when we started, stenting, what we did was we have done few patients where we use anti-inflammatory drug. I talked of curcumin. We use curcumin, we have data till 3 months for curcumin. For some of the patients, published data is only for 10 patients. Because 10 patients is no number. But that was for the efficacy of curcumin, because though it is safe, but you need to have literature. So that was published. So now we have like almost 100 patients. So plaque stabilization was faster when we used curcumin compared to standard medical treatment. Obviously, we use standard medical treatment in addition to curcumin. So that's what it is. It takes, let's say, 1 month. Otherwise, it takes time. Whatever the previous studies we have, present medical treatment will have, 6 months, 3 to 6 months at least for the plaque to stabilize.
Any more questions?
What is the least amount of stenosis that you have done?
No, I have not done. See, what I'm trying to tell you, because I'm not allowed to do, I cannot stand at 20% stenosis. But this is something I'm looking at. Maybe a 40 to 50% stenosis if I find it significant. These are all under research. So this is not something I follow as a routine practice. So I would take at least 50% stenosis before I modify them. But these are the trial, and maybe in times to come things would change.
I only ask because it's interesting. We follow certain criteria, but your results are good. So as practitioners,
Because those are initial results are all high risk patients, initial patients. Out of these patients which we did. But as I said, it is because I think when we were not doing plaque imaging, we were preparing plaques better before we stented.
So if the plaque morphology is dynamic, how do we know that we are not overstenting some of the patients whose plaque morphology might change in the coming days?
It does change. So that's the problem. If you wait 6 months, for a plaque to stabilize with medical management, you may have stroke in 10% cases. So that's the catch. It will change. It will become stable at one point of time. But before that, it can produce devastating results. So you really need to do it as fast as you can.
So we have to have a study where some patients whose plaque morphology is probably unstable are stented, some are not, based on how much amount of stenosis they have, and then the comparison has to be done.
Yeah. So we need to have larger studies. That's what I'm telling you. We need to have larger studies. We need to have different kind of plaques also. Probably as of now we are doing a 50% stenosis, unstable plaque. If you do too much, balloon dilatation, everything will go up in the brain. So that was a contraindication earlier for stenting. With historical cases, large lipid code, ulcerated fibrous cap were contraindication for stenting. But probably if you make a stent which is like a bandage on the wound, in times to come, that might be a medicated stent probably. So that is just future ahead probably.